At a House hearing on drug abuse, a panel of doctors and addiction experts talked about how to treat the problem and what federal resources are needed. This hearing of the House Energy and Commerce Subcommittee on Health is an hour and 15 minutes.
Good. That makes perfect sense. Ladies and gentlemen, if you can take your seats, the subcommittee will come to order. We're reconvening this hearing. We had the first panel a couple of weeks ago, and this will be the second panel. So welcome back. For those of you just joining us today is the second day of our hearing to examine legislative proposals to combat our nation's drug abuse crisis. On the first day of the hearing, which took place on October 8th, we heard testimony from a panel of federal witnesses representing DEA, HHS, and the Executive Office of the President. Today, we will hear from a number of distinguished doctors with a wide variety of expertise. On our panel today, we have, and I'll introduce them in the order of their presenting their testimony. First, Dr. Paul Halverson, Dean, Indiana University's Richard M. Fairbanks School of Public Health. Welcome.
Thank you.
Secondly, Dr. Chapman Sledge, Chief Medical Officer, Cumberland Heights. Welcome. Third, Dr. Robert Corey Waller, Chair of the American Society of Addiction Medicine's Legislative Advocacy Committee. Welcome. Then Dr. Kenneth Katz, Department of Emergency Medicine, Section of Medical Toxicology, Lehigh Valley Health Network. Welcome. And I don't see Dr. Alan Anderson yet, President of the American Orthopedic Society for Sports Medicine. So thank you for coming. Your written testimony will be made a part of the record. You'll each have 5 minutes to summarize your testimony. And after opening statements, we will do the questioning. So, Dr. Halverson, you're recognized for 5 minutes for your summary.
Thank you, Mr. Chairman. Chairman Pitts, Ranking Member Green, Representative Brooks, thank you for the opportunity to testify today. I come before you today as both the founding dean of the Indiana University Richard M. Fairbanks School of Public Health at IUPUI, as well as the former state health officer of Arkansas, to discuss a very important and far-reaching public health issue, the heroin and prescription drug abuse epidemics, and the deleterious effects which we're experiencing across the country and in my home state of Indiana. We know addiction is a tragedy, not for the addicted person alone, but also for families, employers, and entire communities. Addiction is often at the root of myriad social, physical, mental, and public health problems. It harms all in its path, even the most innocent among us. Newborns who have been exposed to opioids in utero are often born with a condition called neonatal abstinence syndrome. In the last 15 years, the number of affected babies is 5 times higher, mirroring the surge in opioid abuse over the same time period. The financial costs of drug addiction for health care, criminal justice, and education are staggering. In my state of Indiana alone, the costs are estimated at over $7.3 billion annually. Hospital charges for babies born with NAS, over $1.5 billion nationally in 2013. Opioid abuse is particularly pernicious because it's often a precursor to heroin use. SAMHSA found that nearly 4 out of 5 new heroin users took non-medical prescription pain medication before taking up heroin. The end result, people are dying. CDC notes that 44 people die each day in our country from an overdose of pain medication. Nationally, heroin-related deaths have escalated over 39% between 2012 and 2013. And although mortality rates are up in many states in the country, Indiana is one of only 4 states where the rate of overdose deaths has quadrupled in 14 years. Indiana made the national news this past spring with its public health crisis related to opioid abuse. Scott County, a population of less than 25,000 people, had an unprecedented outbreak of HIV related to needle sharing among intravenous drug users injecting prescription opioids. To date, the number of new confirmed cases of HIV for 2015 exceeds 180 people. This number is particularly alarming since the entire southeastern region of Indiana has never had more than 5 new cases annually prior to this year. In addition, significant cuts in already chronically underfunded public health infrastructure nationwide make communities even more vulnerable and frequently leaves them without important public health services such as education on how to protect themselves against life-threatening diseases and access to confidential HIV testing and treatment, among other important services like epidemiology and outbreak investigation capacity. Indiana's public health system is particularly vulnerable with our overall health ranking at 41 and our funding of public health services at 47 out of the 50 states. Between 2009 and 13, this small rural county led the entire state in both drug overdose deaths and non-fatal emergency department visits due to opioid overdose. It's also important to point out that there are numerous counties in Indiana and, frankly, throughout the country that are strikingly similar by virtue of their social and demographic characteristics, as well as the fragile public health system capacity that exists. We're grateful to colleagues from the CDC for assisting our state health department under the leadership of Dr. Jerome Adams as they responded to and supported local public health and community leaders, and to Governor Pence for recently establishing an executive branch task force to focus state government agencies on the system issues surrounding substance abuse. In addition, our Attorney General's longstanding prescription drug task force has been focused on the coordination and oversight of Indiana's prescription drug monitoring program, and its insight has been instrumental in developing legislative and policy-level recommendations. Lastly, I'd like to acknowledge the support that the Richard M. Fairbanks School of Public Health has provided, primarily through the leadership of Dr. Joan Duvey, who has tirelessly led and supported these efforts in our state. In spite of these important state efforts, though, additional national legislative efforts are needed. We're grateful to Representative Brooks and other members of the committee for shedding light on the very serious problems of opioid abuse and heroin use, which are becoming more pervasive with each passing day. It's clear we need to effectively attack these problems from a system perspective to prevent further destruction of our public's health. I applaud your efforts, and I'm grateful for your dedication in addressing this important public health issue. Thank you, sir.
Chair, thanks, gentlemen. Now recognizes Dr. Sledge. 5 minutes for your summary.
Thank you, Mr. Chairman. I want to thank the committee.
Make sure you press the button. All right.
Thank you, Mr. Chairman. I want to thank this committee for holding this important hearing on legislative solutions to combat the worsening drug crisis in our country. Like all of us, I'm deeply concerned as to what I see happening in regards to the opioid epidemic in particular. And I'm grateful to have this opportunity to share my thoughts and experience. I'm Chief Medical Officer of Cumberland Heights, a private, not-for-profit addiction treatment center on the banks of the Cumberland River in Nashville, Tennessee. I previously served as Medical Director of Addiction Treatment Services at Pine Grove Behavioral Health in Hattiesburg, Mississippi, and have been practicing addiction medicine for over 26 years. I'm certified by the American Board of Addiction Medicine. I'm a fellow of the American Society of Addiction Medicine, and from 2005 to 2009, I represented Mississippi, Alabama, Florida, Tennessee, and Kentucky on the Board of Directors of ASAM, and served as Secretary of the organization until 2011. Cumberland Heights has a 50-year tradition of treating addiction. We provide treatment to adult men and women as well as adolescents. Most of our patients are working class and insurance dependent, but we treat a fair number of patients with resources to self-pay, and we treat a fair number of patients dependent upon scholarships to provide their treatment. A watershed moment in my career as an addiction medicine specialist came around 2006 on a Saturday morning. I was making rounds on a detox unit with 25 beds, and I realized that every single one of those patients had a diagnosis of opioid dependence, and that was new to me. Some of those patients had other diagnoses as well, but every single one of them had a diagnosis of opioid dependence, and in fact, every single one of those patients was dependent upon prescription opioids. Our most common diagnosis at Cumberland Heights of the 1,500 admissions per year has been opioid dependence, particularly in young adults. Tennessee leads the nation in prescriptions for opioids per capita. And heroin addiction has become more and more prevalent as access to prescription opioids becomes limited through less abusable formulations, monitoring of controlled substance prescription databases, as well as education. The Tennessean, Nashville's local newspaper, ran a cover story on the opioid epidemic last month. To quote, at least 1,263 Tennesseans died last year from opioid overdose, up 97 deaths from 2003, a staggering statistic that points to growing abuse despite an array of measures to stem addiction. More people died in 2014 from opioid overdose in Tennessee than by car accidents or gunshots. My expertise is based in direct patient care. I'm an expert in what my patients disclose to me face-to-face in my office. Almost all of our patients admitted to Cumberland Heights for treatment of opioid dependence have some experience with buprenorphine, either by prescription or by buying the medication off the street. Over the years, I've been amazed at stories of diversion and abuse of buprenorphine among patients presenting to Cumberland Heights for treatment. Buprenorphine is sometimes used under the tongue as it's designed, can be used intranasally or even injected. Motivations for illicit use of buprenorphine include to get high, as well as to treat withdrawal. Of course, some patients with buprenorphine diversion and abuse take it with the motivation to stop using other opioids. A typical 8 milligram dose of buprenorphine costs $20 in Middle Tennessee when obtained illicitly, and in East Tennessee as much as $40 per 8 milligram dose. The street value supports my observation as to the level of diversion and abuse of buprenorphine. In fact, buprenorphine has been identified as the third most diverted medication in the U.S. by the DEA. At a 2008 meeting of the American Society of Addiction Medicine's Medical Scientific Conference in Miami, I was asked by a colleague if I used buprenorphine to treat opioid dependence. I replied that we utilize buprenorphine to detox from opioids. He remarked that he had never seen a patient recover without buprenorphine, and I told him that I had recovered from opioid dependence without buprenorphine. He said, yeah, but you weren't using intravenously. He appeared incredulous when I told him that I had recovered from IV opioid addiction without buprenorphine or methadone. I cringe when an addiction medicine treatment provider makes a recommendation based on his or her personal experience in treatment and recovery. That's not what I'm saying, but my experience indicates that there are multiple paths to recovery. There is no one-size-fits-all. At Cumberland Heights, we promote abstinence after detox. We provide psychosocial treatment, and we use a long-acting opioid blocker, Vivitrol, as well as incorporation of spiritual basis of recovery through 12-step facilitation. We completely understand that addiction is a chronic illness and ongoing recovery requires ongoing treatment. No one is claiming that detox from opioids alone will result in recovery. And I thank you for the opportunity to speak.
Chair thanks, gentlemen. Now recognizes Dr. Waller. 5 minutes for your opening statement.
Thank you, Chairman Pitts and Ranking Member Green. Thank you very much for inviting me to participate in this important hearing. I'm grateful to you and the other members of the subcommittee for your leadership in addressing the epidemic of opioid addiction currently ravaging our country. My name is Dr. Corey Waller, and I'm the chair of the Legislative Action Committee of the American Society of Addiction Medicine, also known as ASAM. This testimony is offered on behalf of ASAM, myself as a practicing addiction specialist physician, and my patients who were unable to speak before this committee themselves. I'm board certified in both addiction medicine and emergency medicine. I'm the medical staff chief of pain medicine to the Spectrum Health Hospital System, as well as a substance use disorder medical director at a regional community mental health organization based in Grand Rapids, Michigan. My testimony today will focus on the following 3 facts. Addiction is a chronic disease of the brain that leads to characteristic biological, psychological, and social manifestations. Addiction involving opioid use can be successfully treated with a combination of medications and psychosocial interventions, and we have published guidelines that detail best practices for the use of these medications. There are significant barriers to access these effective medications, resulting in a significant addiction treatment gap in our country. This is without question a chronic neurobiological disorder that starts with a genetic risk, is informed by the environment, and is solidified by the culture surrounding it. Not unlike diabetes or hypertension, we can effectively manage the disease, but stopping that treatment prematurely costs us lives. We're here today to provide recommendations on how best to respond to the epidemic of prescription opioid and heroin misuse, addiction, and related overdose deaths. According to the Centers for Disease Control, we have reached epidemic levels in our country. We've all seen the data and heard the shocking statistics, but what's not said or heard enough is that the 2.3 million people who need treatment for opioid addiction have a chronic disease of the brain. While we need to prevent other Americans from developing addiction, these 2.3 million people need treatment now. There are currently 3 medications that are FDA approved to treat opioid addiction. Methadone, which has been used in highly regulated opioid treatment programs since the 1960s. Buprenorphine, which has been used since 2002 by physicians who complete a special training in their offices. And naltrexone, which is not a controlled substance and can be administered by any licensed prescriber. All of these medications have proven to be clinically effective. A 2013 review of the scientific literature found substantial, broad, and conclusive evidence for the effectiveness of all 3 medications, and for methadone in particular. Notably, the literature on efficacy of these medications is not new. There are now 8 large-scale, rigorously conducted reviews of the literature on these medications since the early 80s. All FDA medications have been shown to reduce mortality. Finally, we have a clear and comprehensive guideline for how to use these medications effectively in the clinical care of persons with addiction. However, despite the strong evidence-based use of these medications and the clinical guidance available, very few eligible patients are offered medication to help treat their disease. Less than 30% of treatment programs offer medications, and less than half of eligible patients in those programs receive medications. Indeed, a study published just last week in the Journal of the American Medical Association found that 80% of Americans with opioid addiction don't receive treatment. This treatment gap is attributable to many factors, some more complex than others. Research has demonstrated significant access barriers to methadone, including waiting lists for treatment entry, limited geographic coverage, limited insurance coverage, and the requirement that many patients receive methadone at an OTP daily. Data 2000 was intended to expand access to addiction treatment across geographies and populations by integrating it into the general medical setting. In recent months, my practice has had to turn away patients due to the 100-patient limit for buprenorphine, and this includes pregnant patients as well as the children of my friends, and has resulted in at least 2 overdose deaths that we can track. If I am out of town or unavailable, my physician assistants are unable to see patients who need an urgent intake due to the restrictions on PAs and nurse practitioners writing for buprenorphine, which exists even if they are under the guidance of a physician who is board certified in addiction. It is important to note that the entire purpose of Data 2000 was to make opioid addiction treatment available outside an OTP, in traditional physicians' offices, both to increase access in areas where OTPs may be physically inaccessible and to reduce the stigma and patient burden associated with visiting an OTP for treatment on a daily basis. Still, because diversion and quality of care remain legitimate concerns, ASAM has proposed a gradual and limited lifting of the Data 2000 limits. By coupling a lifting of the patient limit with increased training requirements and accountability for those physicians treating large numbers of patients, we feel we can expand access while also ensuring a certain quality of care. Still, this single strategy should be just one part of a broader federal effort to ensure safe prescribing of opioids for pain, alternative pain therapy options, and early identification and treatment of addiction. Pain and addiction education should be required curriculum in medical school and encouraged as continuing medical education throughout a physician's career. Communities should have the resources to educate their citizens about these issues and the outreach and surveillance resources necessary to better understand the unique issues and needs. Thank you again for the opportunity to present here today. ASAM and myself look forward to a continued collaboration on this and other addiction-related issues.
Chair, thanks, gentlemen. Now recognizes Dr. Katz. 5 minutes for your summary.
The drug epidemic confronting this nation has exploded in recent years due to the accessibility of cheaply made, mass-produced, deadly synthetic drugs. As a physician on the front line, I have witnessed how these dangerous compounds have directly led to violence, hospitalizations, and deaths. For example, in both the adult and pediatric intensive care units in Allentown, Pennsylvania this spring, I spent countless hours at the bedside caring for many patients suffering from the toxic effects of synthetic marijuana, which ripped through eastern Pennsylvania, leaving in its wake multiple patients in emergency departments, hospitals, and unfortunately morgues. Mr. Chairman and members of the subcommittee, my name is Dr. Kenneth Katz, and I am board certified in emergency medicine, medical toxicology, and internal medicine. Thank you for allowing me to testify today on behalf of the American College of Emergency Physicians to discuss the dangers posed by synthetic drugs and to advocate for enactment of H.R. 3537, the Synthetic Drug Control Act of 2015. In every community across the nation, my colleagues and I are treating more and more patients who have experienced synthetic drug toxicity or poisoning. It's important to understand that the term synthetic drugs we're using here today describes substances that are primarily manufactured in clandestine Chinese laboratories and actually represents an amity of chemical combinations that are designed to mimic the effects of illegal chemicals with stimulant, depressant, or hallucinogenic properties. They are non-organic, chemically synthesized, unsafe, recreational drugs that produce psychoactive or mind-altering effects. Many of these substances are marketed as innocuous products such as incense, plant fertilizer, or air freshener, and then sold in convenience stores, gas stations, or online. Because of their commercial availability, many users presume they must be safe. However, the public should not be fooled. Even though these products may be hiding in plain sight, they are colorfully packaged poison. Unlike most illicit drugs, synthetics can contain a vast array of different chemicals with varying potencies. For example, synthetic marijuana may contain compounds 200 to 500 times more powerful than THC. In many cases, the manufacturer's only goal is to alter the chemical compound in such a way to technically create a new compound, allowing them to circumvent legislative and regulatory bans. This modification process poses increasing risks to users who are unaware of the reactions the new chemicals or formulation may cause. It is not until these substances are ingested or inhaled that some or all of the following symptoms can occur: hyperthermia, elevated blood pressure and pulse, severe uncontrollable agitation, seizures, coma, muscle breakdown, kidney injury, and ultimately death. Unfortunately, at that point, it may be too late for either my emergency medicine colleagues or even me as a medical toxicologist to save them. While there is an increasingly expanding array of synthetic drugs being manufactured, a particular concern to ACEP is the availability and high use of synthetic marijuana. Whether it's the data from Samson's Drug Abuse Warning Network, DEA's National Forensic Laboratory Information System, or Poison Control Centers, it is clear synthetic marijuana use has increased exponentially since it first appeared in the United States a few years ago. For example, according to NFLAS, there were 21 reports by 2009. By 2012, that number grew to more than 29,000, an increase of more than 1,400%. Through the first 6 months of 2014, there are already close to 20,000 synthetic marijuana drug reports. My home state of Pennsylvania has been especially hit hard by the increased use of synthetic marijuana, trailing only New York, Mississippi, and Texas in the number of reported exposures this year. Currently, all 50 states have banned some cannabinoids and cathinones, with the majority doing so through legislation. Since synthetic compounds are easily manipulated to make new drugs, many states have passed laws targeting entire classes of substances or use broad language to describe the prohibited drugs. Federal statutes must also be updated to meet this constantly evolving challenge and restrain these dangerous products. Synthetic Drug Control Act of 2015, sponsored by Representatives Charlie Dent and Jim Himes, would amend the Analog Act so that a substance can be treated as an analog if it is chemically similar or produces a similar clinical effect. In addition, the bill would add more than 200 known synthetic drugs to Schedule I of the CSA. This legislation is targeted at the manufacturers and distributors of synthetic drugs, not the end users. H.R. 3537 would amend the Analog Act so that it would only apply to the sale, manufacture, import, and distribution of drugs, not simple possession. The easy access to and thoughtless use of synthetic drugs by those who are unaware of their dangerous toxicities not only places their health and lives at risk, but can have a profound impact upon my ability to care for all my patients. When users of synthetic drugs need emergency medical attention, they are utilizing precious resources such as ambulances, emergency department beds, hospital personnel, and limited healthcare dollars. It is by both my opinion and that of the American College of Emergency Physicians that this critical issue must be addressed through the enactment of H.R. 3537 and supplemented by a national campaign to educate Americans about the dangers of using synthetic drugs. Thank you.
Chair, thanks, gentlemen, and now recognizes Dr. Anderson. 5 minutes for your summary.
Good afternoon. I'm Dr. Alan Anderson, an orthopedic surgeon specializing in sports medicine. I'm also the president of the American Orthopedic Society for Sports Medicine, or AOSSM. It's a nonprofit organization made up of 3,400 orthopedic surgeons specializing in the care of athletic injuries at every level of competition. 80% of AOSSM members are team physicians, and 60% of our members take care of high-contact collision sports where serious injury can occur. A team physician has unique responsibilities and qualifications. He or she must have fundamental knowledge of on-field emergency care and treatment of musculoskeletal injuries and medical conditions. Today, I will discuss the need for a team physician to be able to carry controlled substances when traveling with the team and the problems with current law. The fact that workarounds are not practical and why H.R. 3014, the Medical Controlled Substances Transportation Act, will enable team physicians to provide the best quality medical care to our injured athletes. In emergencies or disasters where there is significant trauma, it is critical that a physician have immediate access to controlled substances. There are times, such as during air travel or on a bus, when the team physician is the only medical person available. There are documented cases of players having seizures after concussions on a flight home, and in such situations, controlled substances are needed to stop the seizure and perhaps save the athlete's life. Additionally, it is humane care to allow a player to take a pain pill if he or she has a broken bone, dislocated shoulder, or torn ACL. As you watch your favorite team on Saturdays, one or more athletes is significantly injured in almost every game. These players are your constituents from every state. The team physician, who is probably a member of AOSSM, is there on the sideline to render aid and take responsibility for the athlete's well-being. This aid is being severely restricted by current law. The current law prohibits the transportation and storage of controlled substances away from the site of storage that is registered with the DEA. This makes it illegal for team doctors to transport a limited quantity of critical medications that are needed for pain control or emergency management. This is highly problematic for athletic team physicians who need the ability to maintain a limited supply of controlled substances if a player is injured in an away game. The current law also precludes controlled substances from being transported within the same state or across state lines. The current workarounds are problematic. Current options include pre-dispensing medications to every member of the team prior to travel. That would be 80 members on a football team. This would create a logistical nightmare. Delegating the dispensing of controlled substances to the home medical staff in the state of entry. This is also a problem. The opposing team physicians can provide medications, but they have to independently examine the patient, and they have limited time due to demands to treat their own team. This would also create malpractice concerns for that physician of prescribing medications and not following that patient. There are also privacy concerns. The local physician is generally caring for the competing team. This would be unacceptable for the coaching staff to enter the training room. H.R. 3014 would address these concerns. It allows a physician who is traveling with a team the ability to appropriately manage the injury in a similar fashion to when they're in their home facilities. It does not diminish the need or requirement for controlled substances to be monitored at the current level. Records of controlled substances dispensed are maintained and subject to inspection by the DEA at any time. The team physician will be responsible for the security of the controlled substances throughout the entire time the team will be traveling, and the duration of transport is limited to 72 hours. Military flight surgeons and rural large animal veterinarians have an exemption to carry these medications. Contact sports can be much more perilous than non-combat military maneuvers. It is also hard for me to believe that horses and potentially cows could get better medical treatment than our athletes. This legislation would also benefit patients and physicians who donate their time in declared disaster areas in their states or other states. Therefore, we urge you to support H.R. 3014, the Medical Controlled Substances Transportation Act, so that we can provide the highest level of care for our injured athletes. Thank you for giving me this opportunity to testify, and I'm happy to take questions.
Chair, thanks, gentlemen. That concludes the opening statements of our second panel. I have a UC request. I'd like to submit the following documents for the record. Statements from the College on Problems of Drug Dependence, the National Association of Convenience Stores, Dr. Cooper, head team physician of the Dallas Cowboys, the Fraternal Order of the Police, the Society of Former Special Agents of the FBI, the American Medical Association, the American College of Emergency Physicians, the American Association of Orthopedic Surgeons, Center for Lawful Access and Abuse Deterrence, the American Academy of Physician Assistants, and the National Association of Chain Drugstores. Without objection, so ordered. I'll begin questioning. Recognize myself 5 minutes for that purpose. Dr. Halverson and Dr. Sledge and Waller, you can respond here too. Do you all agree that patients addicted to opioids should receive treatment based on their individual clinical needs? Dr. Halverson?
Yes, sir.
Dr. Sledge?
Absolutely.
Dr. Waller?
Yes.
How would you each advise HHS to take this principle into account when considering how to responsibly implement Secretary Burwell's recent announcement to expand the use of medication-assisted therapy? Dr. Halverson?
Since I'm not a physician, I'd like to defer to my colleagues here.
Okay. All right. Dr. Sledge?
And I think that prescribing physicians should be trained in all modalities of medication-assisted therapy as well as other options, particularly psychosocial treatment with abstinence as an option.
Dr. Waller?
So we've looked at this very closely in the area that I'm in charge of a 7-county area with patients and figuring out how to treat that 7-county area. We've been able to delineate 2 separate groups of patients, which we have good data for. Those that started very early in life and started earlier than in their adolescence, which have a different brain disease than started later in life. Those groups of patients actually separate us out a little bit as far as how treatment works. I have many patients in my clinic that are physicians, pilots, and lawyers who I don't give any medication to because generally it's not indicated, and we have wonderful outcomes without any medication-assisted treatment for those groups because of many other factors. My groups, which are 92% of my patients, which are Medicaid patients or those without insurance, I find that it is a perilous journey to try to treat them without buprenorphine, and the data backs that up with a high mortality rate associated with this group of patients specifically. And so Dr. Sledge and I are saying the same thing. It is absolutely the right treatment for the right patient at the right time, and making sure that we allow for an expansion of use of these medications that save lives in the hands of those people who are trained best to use them.
All right. You've touched on this, but expand a little bit more on how should differences in certain types of patients and treatment settings and therapeutic options be addressed?
Well, currently we have guidelines that directly do address the utilization of the medications. These are the first this is our first guidelines that look at all 3 of the FDA-approved medications, and it does speak to the behavioral and psychosocial therapies without medications within there. Generally, the medication treatment has been done in a cohort of patients that do not represent a physician or a pilot or a lawyer, which in general, we have programs within states that surround them that are different than the general programmatic treatment pathways. And so utilizing the guidelines that we have delineated with the appropriate education to back that up would be the way that I would say.
Dr. Sledge?
An overarching principle identified by the Institute of Medicine for successful treatment included patient self-determination, and I think that that H.R. 2872, the Opioid Addiction Treatment Modernization Act, brings patient self-determination back to the equation.
In your opinion, what are the most significant obstacles at the present time preventing more individuals with opioid use disorders from receiving the most effective treatments?
I think that one-size-fits-all treatment is very detrimental to addressing the opioid epidemic. I think that an assessment of each individual patient with recommendation and referral based on their individual needs is essential for successful treatment.
Any other significant obstacles, Dr. Waller?
I think the legal obstacles to be able to obtain the appropriate medications for patients if we deem it's the right medication for them, such as specifically buprenorphine for my patients. I treat all of the pregnant patients in that 7-county area, and I'm out of space. And so I have to turn people away to areas that are either less than optimal for them or try our best with what we can do. But unfortunately, that doesn't turn out very well.
Can each of you comment on the role nurse practitioners and physician assistants play in providing office-based opioid treatment?
I'm not a provider of office-based opioid treatment, so I'll defer to Dr. Waller.
Dr. Waller?
Without the utilization of my physician assistants, my office doesn't run. We have the capability to see patients in volume because we have well-trained physician assistants and nurse practitioners that work directly with board-certified people in their other specialties, whether this is a neurosurgeon or an orthopedic surgeon or an addiction specialist. And in this case, in addiction specialty, coupling my physician assistants along with behavioral therapists with my patients, it works out really well, and we have great outcomes from this. And this is a model that's been adopted in the medical home model of care and is relatively standardized throughout medicine. And so to eliminate this as a possibility for this specific disease doesn't make sense from a monetary standpoint nor a patient delivery standpoint.
Thank you. About a time, but Dr. Katz, you talked about synthetic drugs, and with the movement towards legalization of medical marijuana, is synthetic marijuana considered medical marijuana? Are the advocates trying to include that in medical marijuana?
Not that I'm aware of. No, I think we're talking about two different things.
Yes, it's completely synthetic.
Yes.
Yeah, that's what I thought. Thank you. And at this time, Chair recognizes the gentleman from Maryland, Mr. Sarbanes, filling in for Ranking Member Green.
Thank you, Mr. Chairman. Before I ask my question, I'd ask unanimous consent to enter a letter from the Purdue University College of Pharmacy, Dr. Nichols, which provides some additional perspective on this issue of adding certain synthetic drugs, to the Schedule I CSA and the implications of that for scientific research.
Without objection, so ordered.
Thank you. I appreciate the testimony, everybody. The first question I wanted to ask was, and maybe Dr. Halverson from your sort of public health perspective, and Dr. Waller, but others as well. The word epidemic is getting used a lot to describe this, and I frankly myself didn't appreciate that by the CDC definition of epidemic, we've actually gotten to that point. Can you comment on, because you know, epidemic gets kind of used in the vernacular to just describe something that's sort of out of hand and serious, but you know, if you're talking about epidemic where it could be, you know, analogous to a SARS epidemic or a MERS epidemic or an Ebola epidemic, whatever, that's of a different scale and degree. And if you could speak to that, any of you, yeah.
Epidemic is used in large part because of the fact that we don't see an easily controllable end, that we experience the phenomenon, whatever it might be, an epidemic of flu or an epidemic related to any disease where the disease is raging beyond our ability to control it. And the disease has the potential to have a profound impact. And so under those definitions, we certainly have seen an epidemic of opioid abuse, of deaths. And the reality is that we do have an idea of how to address the epidemic, but at our current point in time, we haven't reached the point where we can actually say it is controlled.
Any other perspectives on that? Yeah.
So the two components of an epidemic is susceptibility to something and then to be able to come into contact with that something and have it spread. We have seen exactly that pattern with heroin. If it shows up in a community, those people who have susceptibility from a genetic predisposition and then have already been started on opioids, or in the case, unfortunately, of many areas, young people who this is the first drug they touch, in some cases in early high school, and then they have access and a genetic risk, it grows just like the disease that we look at on outbreak, where it just covers the map, and that's what we're seeing. It kills more people in my state than anything else, and it's all people, you know, that are young and healthy as compared to other diseases that affect a whole different population of people.
So let's say tomorrow you were appointed the opioid addiction czar in the same way that we had an Ebola czar, right?
I accept.
Well, okay. And you could take whatever steps you thought were necessary. Describe what the first 2 or 3 things would be, both ones that would require additional resources, would be resource dependent, as well as, it seems, ones that maybe are not resource dependent, like lifting some of the caps on the number of patients that can be treated and so forth. What would your steps be?
Well, I think the first step would be a re-education of the population about what the disease of addiction is. That this is a chronic neurobiological disorder that has more data about the brain disease aspect than any other mental health disease in the history that we've ever looked at.
So is that PSAs? I mean, what is that? Was that how do you get that word out?
This is, a Surgeon General's report. This is public messaging. This is rebranding of a disease that has been maligned in the face, and we have been treating this with an emotional context rather than a science context for years.
Gotcha.
So that has to be the first place.
Okay.
The second piece is access to all treatments, and the third place is to build a structure around those treatments so that they are delivered with high fidelity and low risk. Okay,
thank you. I'm interested because I've got a piece of legislation on this topic of this idea of encouraging co-prescribing of naloxone at the time that a physician is prescribing a certain kind of opioid. There would be some demonstration projects around this to test the potential of this and to look at the particular circumstances under which that would be appropriate, the kind of patient, their particular vulnerabilities, and the likelihood of a potential overdose, et cetera. Can you just speak to your perspective on whether that would be a useful step?
Well, first, Congressman Sarbanes, I appreciate that piece of legislation. It is very impactful. I carry naloxone in my backpack. It is sitting behind me in a ready injectable pen because it's something that we can do. It is a anti-death serum. And so to have this available in a co-prescribing way to family members and to patients alike, and to make sure that they are trained in the utilization of this is no different than having an automatic defibrillator on a wall in a gym. I mean, this is something that should be publicly available, and this is a great step toward that. We definitely support that. I personally support this, as well as with ASAM as well. I think the biggest issue with this, we need to make sure and dispel the myth that somehow adding an antidote changes patients' behavior to use more and more often. That has been found through research to not be true. In the areas with which we have allowed this to be legalized and given to police officers and community members and made it available to patients, we have seen nothing but a decrease in mortality. We have not seen an increase in utilization. We have not seen an increase in amount of utilization per person per time they use. That is just not true. And when you reverse somebody, that's one more time that they're not dead, and two, we have an opportunity to get them into treatment.
So you have to bring all the other measures to bear and view that as kind of a first step back to that opportunity.
Absolutely.
Yeah.
Yes,
thank you very much. I yield back.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the Subcommittee, Mr. Guthrie. 5 minutes for questions.
Thank you very much. And first, as a comment to Dr. Anderson, I know you got up here early. I saw you on the airplane, I believe, coming out of Nashville this morning. And appreciate, and I'm also working with not your organization, but people that practice in your area, not just for opioids that you're talking about being able to carry, but also a friend of mine is a emergency room physician in Auburn, Alabama. So we traveled to Kentucky last Thursday night with the Auburn Tigers to watch over the team while they're playing our beloved Wildcats. And there's a licensing issue too back and forth about a physician licensed in Alabama to travel with the team into Kentucky. We need to fix that as well, and that's something we're looking forward to doing. Second thing, on a lot of my good friends back in the legislature in Kentucky, former colleagues of mine, were very aggressive on OxyContin and prescription drugs and put forth ways to manage prescription drug abuse and seemed to be very successful with it. And I know some of the physicians were really having to manage it very closely. And we thought, wow, we really are getting a big handle on the supply of the problem, which supply is still a problem. You got to tax supply all the way. And all of a sudden, heroin became a big component in Kentucky. And it became, somebody told me, I had lunch yesterday with one of our drug task force leaders, and he said it's easier to get heroin now than prescription drugs in Kentucky. I mean, illegal prescription drug, use of prescription drugs. And so we have to attack the demand for it as well, and what you guys do. So one of the questions I have, for those of you who practice in this area, I know Dr. Halverson, I have a question for you too, but I don't think you said you're not an MD. But and even would like to answer, I know there are caps on what practices can use for buprenorphine. And the question is, do you think the current cap should be lifted? And if not, why? And if so, how? So any of you practice in this area, I'd love for you to answer that question.
So I can address it initially. The short answer is yes, but safely. Mm-hmm. We've identified that this medication is diverted. And in some cases abused. I have patients that I treat for buprenorphine abuse. They show up and I treat them for that. And now that we have the abuse deterrent versions, The inadvertent utilization of it through snorting or injection has significantly declined to the point where we generally don't use the mono drug, the buprenorphine by itself, at all in my clinic.
Do the caps put limits on you that you look at it and say, wow, I could treat more people if I didn't have this cap?
I have a 7-month waiting list, and it's purely waiting on slots.
Because of the cap?
Because of the cap, and I have no one else in my community of 1.3 million people that has any space on their cap that is a specialist in this area.
Both of you practice in this area, I believe, as well. Dr. Sledge, do you have the same issues with the caps?
Well, and again, I don't practice
in that area,
office-based opioid treatment, and there certainly is not a cap involved with extended-release naltrexone and its incorporation as a medication-assisted therapy. And again, with the issue of diversion and abuse, I do think that there needs to be diversion protection in whatever measures are taken to increase.
Let me ask you a question, Dr. Sledge. So you, in your comments earlier, you talked about psychosocial should be added to the, you can't just treat through like buprenorphine and those kinds of things. Why is that important?
Why is that important?
You know, I want you to state the obvious, but I want you to say it for the record why that's important.
Okay. Absolutely, and I think just prescribing the medication is not going to affect much of a change in the course of this chronic disease. It's a chronic brain disease that affects not only with biological manifestations, but psychiatric, psychological, spiritual, and social manifestations, and all of those areas have to be addressed for ongoing recovery. I think that that medication is unidimensional when it's used alone. It addresses the biological manifestations of the disease, but the disease is multifaceted, and all of those areas must be addressed for recovery.
Because everybody, I have one more question. If anybody wants to add to that, if not, thank you for doing that. Also, I guess this is really for the record too, Dr. Halverson, because I think a lot of us understand this, but aside from the chronic health impacts of addiction and death from overdose, what other public health or social impacts are associated in Indiana and nationally in your role? I know you see this nationally with opioid use disorders.
Right. So one of the things that we experienced in Indiana with the overdose patients were related to infections that occurred as a result of intravenous drug use. So again, part of the issue is people overdose on drugs for a number of different reasons. They frequently will also be affected by infections as well as actual other diseases that weren't intended as part of the effect that they were trying to get from the medication. But additionally, there are a number of other issues that are related to the community's overall health and the ability for the community to be resilient around this kind of disease is important to take into consideration. In part, there is, I think, a general lack of understanding around drug abuse in particular. I think one of the questions that was asked earlier was related to what would you do to address the community awareness. And part of that is helping people to understand the scientific basis of this disease. It is indeed a chronic disease, and we need to begin to treat it in that manner and approach it from a scientific perspective. There still are a number of people, unfortunately, that believe that people ought to just quit that. They just ought to stop this, and they don't recognize the fact that this is a disease that needs to be treated. We have to also make sure that people have access to treatment, which is in our state as well as others.
Thanks.
There are
I'm
problems
kind of over my
access.
time, but I appreciate your answer. I know I'm over my time, and the chairman needs to move on, but I appreciate your answer. Thank you. I yield back.
Chair, thanks, gentlemen. Now recognize the ranking member of the full committee, Mr. Pallone. 5 minutes for questions.
Thank you, Mr. Chairman. My questions are of Dr. Waller. As you know, or you mentioned, there are 3 FDA-approved medications for the treatment of opioid dependence. There's methadone, buprenorphine, I guess you've been talking about, and naltrexone. And I'm interested in hearing more about methadone. Could you briefly describe how methadone is used to treat individuals with opiate dependence? And are there special requirements to treat individuals with methadone in the substance abuse context?
Yes, sir. So methadone is a full agonist medication, which means it resembles medications like oxycodone and hydrocodone, morphine in that way. So for patients who have traditionally a heroin addiction and specifically injecting heroin, we have great data that states that utilizing this medication in a fully inclusive biopsychosocial environment, not just the medication itself, but then specifically adding all of these, the biopsychosocial aspects with that, significantly decreases craving for a drug, and by doing that allows them to continue to show up and have a very high retention and treatment rate. So about 75% of patients will be retained in treatment on methadone as compared to buprenorphine, where you will retain at about 65%, and then for new onset with naltrexone, it's lower than that. That number hasn't been fully vetted, but when we look at the...
I guess what I'm trying to find out is why buprenorphine should not be regulated like methadone. That's what I'm trying to get you to...
So the basics are that the regulations around methadone are significant, and for a primary care physician to onboard the regulations, it would be at minimum about $150,000 immediately with the paperwork, the accreditation through the Joint Commission, the accreditation through CARF, and then at that point, you have to actually, there are specific issues with almost all states where you would have to then par with a community mental health, which requires a request for proposals, which requires a hearing. It almost completely negates the capability for a primary care doctor to deliver this medication at all.
But again, I think you were getting at it, but I still don't understand what are the medical reasons to justify why methadone comes with different requirements than the other two drugs?
Well, one, those are historic because that's how it was started, and it's been very regulated since it was initially utilized in this manner since the 60s. Two, it does have a higher potential for abuse than buprenorphine. Three, it has a higher overdose risk than buprenorphine. And so all of those are much lower in buprenorphine, which is why it's Schedule 3 and able to be utilized in an OTP, opioid treatment.
Okay. One of the bills that we're discussing today, H.R. 2872, proposes bringing the regulations for physicians who prescribe buprenorphine in their offices more in line with the regulations governing methadone. And how would this proposal affect patients' access to buprenorphine, or how would this proposal affect our ability to treat special populations like pregnant women who are opioid dependent?
It would completely negate my ability to see my patients, and I would have 200 people without treatment immediately in my clinic. If you look at this from a national perspective, we would shut down any extension or expansion of this pathway, given the amount of money that it takes to get into the pathway and then the amount of regulation surrounding it. So I think that it would be not just me, this is pretty well understood that if that happened, it would be catastrophic and the mortality rate would skyrocket.
So basically, it would profoundly affect our ability to respond to the current opioid crisis, in your opinion?
Unfortunately, yes.
All right. Now, another major access to, the patients already face a number of barriers in accessing medication-assisted treatment, or MAT. And one major barrier to access MAT appears to be cultural social stigma surrounding the use of these medications. Although there's strong evidence supporting the use of MATs, many people, even within the treatment field, continue to believe that using MATs is merely replacing one addiction with another. Can you comment on this perception? Are patients on MATs merely replacing one opioid addiction with another?
The short answer is no, but very specifically, if we look at what we're trying to do, the part of the brain that has been injured is the area that releases a specific chemical called dopamine. These medications re-regulate that so that we can add the beneficial psychotherapies that then stabilize that for long term. Unfortunately, we have found that some patients who have used this for an extended period of time, opioids and alcohol, and at very high doses, they injure that part of the brain permanently, and that they may require stabilization of those chemicals for a very long time, and in sometimes lifetime. We find that we don't keep all of our patients in my clinic on this. We're able to wean a good number of them, but it takes time, and the data is very clear that at minimum it's 18 months to 2 years before the brain begins to heal in that setting.
All right, thanks a lot. Thanks, Mr. Chairman.
Chair, thanks, gentlemen, and now recognize the gentleman from Indiana, Dr. Bouchon. 5 minutes for question.
Thank you, Mr. Chairman. I appreciate it. Thank you to all the witnesses for being here. Very much appreciated. This is a big problem, obviously, that all of us want to help solve. And I was a practicing cardiovascular and thoracic surgeon prior to coming to Congress, and we're talking today primarily about treatment. But we all know we also have to probably address this on the front end with training of physicians beginning in medical school and residency. I can tell you the amount of training that I had even as a surgeon specifically on pain management and the use of narcotics to manage pain was really minimal, other than so essentially on-the-job training during residency. And I think we need to address that moving forward. I had a nice conversation with Michael Botticelli about an hour ago. As you probably know, the Director of the Office of National Drug Control Policy. And I guess President Obama will be commenting on this specific subject in West Virginia tomorrow. And I'll be looking forward to his comments and what they're planning to do to help all of us address this situation. I also want to comment on what Mr. Sarbanes said about naloxone. I think that it is important that especially first responders and law enforcement and probably family members of people who have these issues, as well as maybe the people themselves, have access with the appropriate training. I've used naloxone myself many times, primarily in intensive care units when we felt patients were over-narcotized, but there are ramifications of using it, and we just need to make sure everyone has the training. But I really agree with what Mr. Sarbanes said. The other thing is, I think we need to recognize this goes across age groups. For example, in 2013, the most commonly prescribed drug under Medicare Part D was the generic version of Vicodin, not an antibiotic, but a narcotic. So with that said, you know, I really appreciate all of your comments today, and I agree with Team Doctor, Dr. Anderson. Also, we need to address that situation going forward. Dr. Sledge, can you expand on your experience treating this problem with the available current medications that are out there? Other than, I mean, you obviously use other methods other than medical medication treatment, but your experience at Cumberland also using those options also?
Sure. And I appreciate the question. We
Poke your microphone, please. You know, touch the button on your microphone.
It should.
Hold. Okay.
During the assessment process, it's you know, we offer options. Patients come in very clear with the course of treatment that we would recommend at the time of the assessment. There are a myriad of referrents in the Nashville area if they choose to utilize a different approach. But we use buprenorphine typically to detox, to get the patient opioid free, and with a sufficient period of time, which is very difficult to achieve in an outpatient setting, but in a residential setting with a sufficient period of time of abstinence, we can begin to use a pure opioid antagonist, or an opioid blocker, if you will, naltrexone, and administer that in an extended release formulation that lasts for 30 days in conjunction with their biocycle.
Okay, and Dr. Waller, I was interested in your comments about 2872, since I'm one of the ones that's working on it, and thank you. That we're still working through this, trying to make sure actually we expand access to treatment for patients, and we have a process we're going through that we need to continually work on. The one thing, though, I do maybe slightly disagree on is that we should consider history and we should consider money as part of a reason why to do or not to do things as it relates to drug treatment. I understand the practical aspects of that. So, I mean, what might you suggest? What would your suggestions be to expand really access to outpatient treatment for these problems? Because clearly, as you know, what we have now, we have methadone, buprenorphine, and naloxone. Oh, well, I keep confusing the two. You know what I'm talking about.
I do, yes.
Vivitrol. I mean, we're trying to expand access. If you don't think that we should make sure that everyone is able to offer all of the options for treatment medically, what should we do?
Oh, no, I think that I may have misspoke or been misunderstood. I think all three should be available for sure. I use all three.
Yeah.
On a regular basis. I have a number of patients on long-acting naltrexone, and we use it at the time in which it's right for the patient. For some people, it's right at the beginning. For my population in general, though, it's toward the end of treatment as we've stabilized them on these other medications and let the psychosocial aspects really start to work. So the biggest thing that I think we have to do is make sure that those of us who have access and knowledge and extra training and board certification in this area, much like you did in your training, you wouldn't want a general surgeon doing cardiothoracic surgery. You know, just like we want to be able to help our colleagues in primary care by stabilizing these complex patients and then helping them to maintain them over a period of time and then in that fashion. So I think bolstering the capability for the people who are board certified and trained and focus on this illness to be able to deliver services to a higher number of people with all of the medications is of the utmost importance.
Okay, thank you. I yield back.
Chair, thanks, gentlemen. Now recognizes gentlelady from Indiana, Mrs. Brooks, 5 minutes for questions.
Thank you, Mr. Chairman, for holding this hearing, and thank you all of the witnesses for coming today. I specifically would like to thank Dr. Halverson for being here. Welcome to Washington. It's an honor to have you before the panel, and always nice to have a fellow Hoosier in the nation's capital. And I have to admit, your experience, State Health Director, CDC, now at IU Fairbanks School of Public Health, we're very fortunate to have you in Indiana. And in fact, I want to thank you because Dr. Halverson convened a roundtable at IUPUI with prescribers, pharmacists, members of HHS and VA, and we discussed the challenges Indiana was facing then as unfortunately one of the states leading the country in prescription opioid and heroin drug abuse. And we had quite a discussion that day, and we actually also had someone from the med school who attended, and we appreciated his participation. But one thing that ONDCP, they released a report in 2011 that cited their intent to encourage medical and health professional schools, such as Fairbanks, to continue expanding the continuing education programs for prescribers. More instruction on measuring pain and prescribing to treat it. Now, that was 4 years ago. I think we're still really struggling in the country with getting our medical schools and our continuing medical education programs embracing this concept. And could you please discuss not only your efforts, but I'd be curious from the panel, what are we doing wrong? Why can we not get our med schools and our continuing medical education and other health educators to focus on the prescribing practices? Dr. Halverson, would you please start? Because this is not a new issue. ONDCP said it in 2011. So what challenges, obstacles, what do we need to do to get our prescribers on board with this?
Well, thank you, Representative Brooks. We appreciate your interest specifically in this matter. I would also say that the need is clear. It is my understanding as we look at, we're constantly looking at curriculum, and this is an important issue. I've had conversations with our medical school dean about this issue, but I also know that there are a whole lot of other issues that are also in competition for that time. But I also don't think there's any question about the importance of this education. Certainly, as we look in Indiana around issues of continuing education and the need to inform all of the prescribers around this issue, continuing education is not in dispute. I think really it's been in the implementation, particularly as it relates to reimbursement and just the logistics around getting it in place. But I don't think there's any disagreement around the importance of the education.
Well, I've been involved in higher education before coming to Congress, and I understand that curriculum committees, there's a lot of discussion and a lot of work that goes into providing curriculum. However, when our med schools are saying they get 3 to 5 hours possibly in med school on pain, it's just simply not enough. And at this point, to come up with one set curriculum, I think is a problem. Let's do more. And so what more, and I'm curious, do we need to be requiring it? Does it need to be mandatory? Should there be certain hours that all prescribers are required to take a year? I'm a lawyer. We have continuing legal education credits that we're required to have every year. There are some requirements. What do the other panelists think? This is very troublesome for me, not just for physicians, but nurses, dentists, others who are prescribers. What should we be doing? Any ideas of what can we do to fix this problem? Because we've been talking about it far too long, and our educators haven't resolved the issue.
So 2 very practical possible solutions, and one is to consolidate the efforts of adding to the curriculum for pain and addiction based on the governing body for the national medical schools rather than having a heterogeneous group of medical schools come up with their own curriculum. This curriculum has already been developed by SAMHSA as well as CMS and has been put out there as a recommended curriculum. It is there. Access to it online for free is available in many locations, so you don't even have to have your own specialist, but you need to have them mandate within the medical schools that this is a part of the curriculum. It's currently not.
And unlike my colleague, Dr. Bouchon, who went through med school, I did not, so I don't know what is mandated. Are there other parts in medical education that are mandated, or is it all left up to each individual med school? I am certain there must be a lot of mandatory curriculum items. Can you give us a couple examples of a couple of them, and why wouldn't this be one of them?
Well, the specific example is every medical student has to rotate through the core curricula, and the core curricula hasn't changed in 100 years almost. I mean, when you look at it, it is internal medicine, it is general surgery, and then it is the connections between all of those, pediatrics, and then you rotate through the critical care, the inpatient care, and the outpatient care of each of those. Adding on the specialties has always been an option, and they've seen addiction medicine and pain medicine as a high-end specialty for which many don't have access to rotate. So until you mandate it as a part of the clinical curriculum so they actually stand next to somebody doing this, there is no way for them to glean from a book how hard it is to talk to some of these patients who have had a horrible early life, and they have to see it. And if you mandate that, they will find it, because there are people everywhere. There's a medical school. There's someone who is board certified in pain or addiction to do this. And then, I'm sorry, my friends are not going to like me for this, but I think that physicians who prescribe controlled substances should be mandated to have ongoing, CME, period. And ASAM agrees with that.
I'd be curious, and I see that my time is up, but Mr. Chairman, if I could just ask the panel, I'd be curious if anyone on the panel disagrees with that notion.
No.
No, absolutely not.
Sir?
I don't disagree.
Thank you. With that, I yield back, Mr. Chairman.
Chair, thanks to the gentlelady. Now, without objection, gentleman, Mr. Tonko, a member of the full committee, is recognized for 5 minutes for questions.
Thank you, Mr. Chair, and thank you for the thoughtful discussion by the panelists and to the many in the room who make it their passion to end this epidemic. I understand that the Drug Addiction Treatment Act of 2000, or DATA 2000, was passed to expand access to addiction treatment across geographic boundaries and populations by integrating it into the general medical setting. So for Dr. Waller, can you describe how DATA 2000 expanded access to addiction treatment services in the United States?
Yes, sir. And again, Congressman Tonko, thank you for all your hard work in this area. It's greatly appreciated.
Well, we have good partners, so.
It's a team. So one of the things that it has done is it's allowed for clinics such as mine, which I work for a medical system. I'm an employee of a hospital system, to be able to open our doors and see patients based on referral in an outpatient setting and then deliver the highest quality of care. So it allows for a specialist like me to work in a standard medical setting and deliver care to patients, both for pain and addiction and all of the psychosocial aspects. From a primary care aspect, it does allow them to treat in place, and especially in our rural areas of America, which is the largest part of America, there are no methadone clinics. There are no inpatient treatment facilities for hundreds of miles in many places. And in my home state, Michigan, we have an Upper Peninsula that is devoid of treatment. They don't have a buprenorphine prescriber in the entire Upper Peninsula now. This is a large portion of the population that is left without. So being able to not make this feel like a criminal act to write this medication for patients, not be fearful of the DEA walking into your office while you're seeing a patient for hypertension to write buprenorphine, and then the availability of the medication to prescribe in a thoughtful, safe way is key. It's expanded it in many areas, but we still have a lot to go, and it's for all of those reasons I just stated.
Well, it seems in terms of expanding it, the law expanded access to buprenorphine in some ways, but the law did set certain limits. And it's clear from the current opioid crisis that we have outgrown those rules. And as you know, in 2012, 96% of our states and the District of Columbia had opioid abuse or dependence rates higher than their buprenorphine treatment capacity rates. So I'm concerned that the opioid crisis has outgrown those rules. Could you explain how the current cap of 100 patients, Dr. Waller, has limited our ability to respond to the current opioid epidemic?
We have two areas that we've dug in pretty deeply, both at the national level and me at the local level. One is the first year you can only see 30. You take your 8 hours of education and make sure that you finish the test, and then you get your certification to see 30 patients. The next year you can apply for 100. For that, those of us who are specialty trained cap out at 100 pretty quickly because the vast majority of the patients funnel to us. And so we cap very early within our areas. In primary care, we have a large percentage of doctors who have chosen not to write for this medication, despite having an X license. And so what it looks like is we have a large amount of capacity. Well, we have 423 primary care doctors in my medical group, and I've talked to over 300 of them to find out why they won't write this medication in their practice. And it is very specific, it's consistent. They don't feel like they have the training. They don't feel like they have the support to evaluate and initiate treatment in patients and then stabilize them. They feel comfortable with the maintenance as long as they know they have backup. But the reason that we don't see a lot of primary care doctors raising that, seeing up to 100 patients or seeing the 30 is because they don't feel like they have the appropriate knowledge and backup. When we've offered that, we've seen they do a really good job with this. I mean, their empathy capable, once they learn about this disease, their ability to treat it is really good, but that needs to be stabilized in a specialty setting and then handed off. Therefore, raising the cap for people who do this as a specialty and have board certifications in it would allow us to then hand some of our patients off to primary care over time, but then allow us to not have a barrier, in my case, a 7-month waiting list to see patients.
And do you have an opinion on the current prohibition of certain other professionals that might assist here, a prohibition on non-physician providers prescribing buprenorphine, including nurse practitioners, physician assistants? Does that limit patient access?
It absolutely does. I have 2 physician assistants in my office who are the backbone of my patient evaluation. They're seeing patients as I'm sitting here, but we are limited in what they can do. So if I had an urgent intake, they're frozen. They can't see a new patient and start them on buprenorphine, even if they're under my supervision. I can't pick up a phone. They don't have the legal right to write that prescription. So starting this in a way in which is appropriately supervised and so that they have somebody to go to for the difficult patients and can onboard this knowledge and training is very important. But the access for them to be able to write these from a practical standpoint, it really just has to happen. They are really moving forward the biggest part of our healthcare system.
Thank you. With that, I yield back, Mr. Chair. Thank you very much.
Chair, thanks, gentlemen. That concludes the questions of the members who are present. There will be other members who have questions and follow-ups that we'll send you in writing. We ask that you would please respond promptly. Members should submit their questions by the close of business on Tuesday, November the 3rd. So members have 10 business days to submit the questions for the record. Very informative and important issues we're dealing with. Thank you for your expert testimony. It will help us as we proceed to move the legislation that was subject to the hearing, and I want to thank each of you for coming and presenting the expert testimony today. Without objection, the subcommittee is adjourned.
I'm the leading state sponsor of terrorism.